Thank you. And good morning, everyone. I just wanted to provide a quick intro for this session and then get out of the way. So thank you all for being here. This particular session, I wanted to give a little background on and mention that NATO hosted our Spotlight series focused on health equity and disparities this summer, which you all can actually view on demand on the conference platform right now, just so you know. And during that, the presenter shared interventions at different of the health data life cycle that support improved demographic and social determinants of health data for measurement. I'm realizing that, the next sentence doesn't make sense is what I'm realizing. So we're excited to kind of continue some of that conversation here around data strategies to identify health inequities. And I'm grateful for the support from Jeff Stoddard with BerryDunn's Health Analytics Practice Group, who is organizing this session. So let me bring Jeff on, and I will, thank you, Jeff, for your support with this. And I just want to say I'm looking forward to these presentations.
All right, great. Thanks, Charles. Good afternoon or morning, depending on where you are. And thank you for joining the Data Strategies to Identify Health Inequities session. As Charles mentioned, my name is Jeff Stoddard, and I am the co-leader of the Data Management and Strategy practice within the Health Analytics Group at BerryDunn. We primarily work with state governments and not-for-profit healthcare organizations to provide data management, analytics, health policy, and actuarial services. I am pleased to introduce this session and its speakers. The first presentation is titled Building a Library of Social Data for Integration with APCD Data, presented by Elizabeth Caballero and Caroline Schaefer. Caroline is a data scientist and Elizabeth is a project manager, both from the Center of Healthcare Data from UTHealth. Feel free to ask questions using the chat feature, and we will address them at the end of the presentation. Now we will turn it over to Elizabeth and Caroline for their presentation, and we'll bring them back on stage when the presentation is complete for Q&A. Thank you.
My name is Elizabeth Caballero, and I'm with the Center of Healthcare Data.
And I'm Caroline Schaefer. I'm a data scientist here with the Center of Healthcare Data.
So we are currently we are part of the UT School of Public Health, located in Houston, Texas. Our center has a large data warehouse with healthcare claims data, and it is the largest in all of Texas. What is unique about our center is that we are CMS certified quality entity, and we also have many contracts with the state of Texas for evaluation and consultative. We also work with others, such as researchers within UT School of Public Health and others outside, to address their research questions using our healthcare data sets. Our team of experts on staff have really created this great warehouse where, as you know, working with data, it can kind of be very cumbersome because it kind of comes in all forms. And so what they've done is all the different types of data sets, they've consolidated and streamlined them. So when someone comes to us with a research question, we're able to create a mission or episodes based on what their needs are, and really help query and is really easy to be used when answering any types of questions. Because of our track record, last year we were named the administrator of our Texas All Payers Claims Database. Over the course of the year, our team has been working really hard to kind of get and to build infrastructure support around this and to get it up and running for next year, hopefully by January. So keep on the lookout for that. We were really excited here with the center as well. So why are we here today? So today we're also going to talk about our database that we built, which is for the non-medical drivers of health. And the primary objective for this study, or for this project really, was to build a data sets that are complementary to our healthcare data sets right now. As we know, there's other factors that can influence our health. And so we wanted to bring in those data sets to really inform those who are answering research questions or other community organizations that can drive, whether it's funding areas, intervention development. And so we thought we should add this to our current data sets as complementary. So before we got started, we wanted to learn what those stakeholders throughout the state of Texas really wanted in something like this, or in what they use. So many of you know as non-medical health drivers of health as social determinants of health data. And so what we've learned from talking with stakeholders is they do use this type of data, whether that's to kind of inform their processes, to inform interventions, to identify areas of need. But another thing that we've learned is it's really hard for them to use it. A lot of times they felt the data out there was very overwhelming, or it was hard for them to kind of interpret the data if they don't have data expertise on their staff. A lot of times they also would have liked to have it more granularly by a zip code or a census tract as well. So just kind of working with them to actually really know what will be useful to them. And so now I'll turn it over to my colleague.
Thanks, Elizabeth. So the first part of assembling this database after we learned of all of the needs and wants of various stakeholders was our ETL process, so your extract, transform, and load. As data changes over the years, new variables come up. Some variables are archived and no longer used, so it's important to keep track of what is available at various years throughout time. Also to remove extraneous data, irrelevant data. Sometimes they have very long geographic names for cities, metropolitan areas, but really limiting it to specific code so it's easily matchable or searchable through data sets. And also making the data a bit more concise. You know, as Elizabeth mentioned, sometimes there's data all over the place. It's hard to find it all. So our goal was to format all of this data into relational tables so we could facilitate extracting data quickly, using the data quickly, and also linking with our claims data or EHR data as well. We also automated some Python pipelines to ingest this data, clean it, look for new variables, old variables, and update them as they come out publicly. Next slide. So the benefits of this was a centralized and organized database that people could search by category. If someone is interested in food disparities, they, instead of going to many sources like the USDA, the FDA, perhaps the US Census, they can come to us and say, hey, what information do you have on food insecurity? What do you have on food deserts? And perhaps we can find all of those data sets that they were probably already familiar with, and we may be able to find new ones that they weren't familiar with before. This also includes things like county level, zip code tabulated area, sometimes things at a school district level even we have. So we have all of these crosswalks so that way people can interpolate or extrapolate the data based on what granularity the data are at. We also normalized variable names and descriptions because they can get very cumbersome because they're very important to be exact, but we want to make them more user-friendly. And again, we update them as new data are released. So that way people know they have the most recent versions of data. Next. Here's a current just semi-catalog of our data sets. Obviously, it's not totally comprehensive. There's a lot of data out there and we have a lot. So because of this, we have started to create, next slide, please, a data library where people can come to us, come to our website and ask, you know, what data do we have? What variables are there? What years do they cover within our non-medical drivers of health data library? And here they can see exactly what variables are there, some descriptions about the main source itself, as well as links to the main sources if they want to get more information on them as well. Next slide. So the goal of this is to really build the bridge between our non-medical drivers of health and our health outcomes that we can see within our claims data. Next slides. Our goal is one day to have dashboards like this one where people can look at direct relationships and see, is there a relationship seen between, for example, median household income and emergency visits? Obviously, this is just a mock-up. The data are randomized here for the presentation purposes, but we can allow people to look at the data without having to go through all of the coding, all of the cleaning, and things of the like, and really start to generate hypotheses on what could and could not be causing some of these changes in costs or utilization. Next slide. We also want to create dashboards that help give a snapshot on the quality of care or the different demographics or different social variables within a county, so they can kind of see, hey, how does my county stack against others? Or what about my state legislative region, things of the like. So you can kind of see how things are stacking up across the state. Next slide. So our next steps are to make the library searchable and available online. We're currently working with our web development team on that. Creating the dashboard on demographics, because just getting the most recent counts or archived counts, especially by the many variances of sex, age, race, gender, everything in between, and employment, things of that sort, are always important to have, just to make sure we're all looking at the same numbers, right? And creating a data sandbox where people can play with data, start with some hypothesis generation, and start to see what questions should we be asking? Are there questions that need to be asked and more thoroughly researched? And as always, our database is being continuously updated, and we're always looking for more data out if it's out there. Researchers can come to us and say, hey, do you have this data? And if we don't, we are more than happy to add it to ours. We know that we don't have every single data set out there because it's quite a vast area right now. So we're always looking to update and better streamline this process. Thanks.
So I'll stop sharing there, but as you can see, we are excited to be sharing the current progress, and we are continuing to make strides in our efforts.
All right, thank you for that presentation. That was really good. I really liked those visualizations you showed. Those looked really cool. Nice job on that. And that the data catalog, wow, that's a pretty powerful tool to make that available for folks, for sure. So we have one question from the audience at the moment. And for those of you out there listening, feel free to use the chat, another reminder. So from Karen Hampton, who and what state groups were considered stakeholders?
So yeah, that's a very good question. So they kind of ranged. Our first initial was, of course, going with internal folks at UTHealth and other and sister locations with researchers. But then we went beyond that. We really did talk to nonprofits, such as, for example, the United Way. We also talked with payers and foundations as well. And another thing that we also tried to strategize was not only to kind of talk with those within our area, since Texas is really widespread, we did try to talk to those who are on the west of Texas or the upper Texas as well. So we did try to get a vast voice of individuals. We talked to up to about 20 individuals as well.
Nice, thank you. And what was the driver to build this database?
So I know, since in the beginning of our presentation, we did talk about, we know there's other factors that affect someone's health. And so with the data that we currently have with the healthcare claims data, that doesn't really give the full picture. And so we would like to have built something that kind of gives a little bit about their environment or possible environment, right? Because it's a proxy, since it's not about the individuals thus far, since they're more surveys that we're using. And so with that in mind, we just wanted for others to be able to kind of use this data and pair it to help build better interventions, to help better inform public health officials and policies, and to help strive to make a difference.
Great, thank you. And for your claims data, is it a voluntary submission, or how does that work with the payers in Texas?
Yeah, so I'll take that one. So currently, we receive data from a few specific payers, with by agreement. But now that the APCD is in effect and starting at I believe January 1 of 2023, it is now a state statute, or it is required by law in Texas Department of Insurance to send their claims to us. So currently, for previous years, we estimated we had claims data on roughly 80% of the insured lives of Texans. But once APCD is fully running and fully in effect, that will be supposedly 100%. And that data will also be more current. And then our data right now are usually updated quarterly or annually, depending on the payer. But now with state requirements, it will be monthly. So claims will be much more rapidly updated and more pertinent to the present moment people can be using it.
Excellent. And from the chat, could you talk about the level of aggregation of the data you make available in your library?
Sure. So currently, the most commons obviously are your zip code level or county level things. And those ones we make very freely available, just because you could go to all of these websites yourself, download them yourself as well. But there are some places that download on much more specific. Some of the food information are down to district levels, including like congressional district levels and that's state congressional districts, or on even school district levels, even depending on where it comes from. So it kind of depends on what you're looking for, and if you'd rather have the raw data as opposed to us say interpolating down from, say we have numbers on Harris County and are trying, and then we say we want to get down to your neighborhood level, things like that. That's often seen in like social vulnerability index, right? Like those are things that you don't necessarily have those exact numbers, but you're inferring from how things are around that area and trends compared to many relationships that are happening. So it can really depend on the variable itself, and that's one of the helpful things with that library is seeing what different areas you can look at, and not just your typical zip code county level. I was really impressed with the number of places we found by district, which was really interesting and very helpful for when any kind of legislator is interested in this information.
That's great. Well, thank you, Caroline and Elizabeth. We're going to move on to the second presentation. If you had a question in the chat, we will attempt to get to it at the end of this session, where we'll bring back all of the presenters. So for the next presentation, the title is Health Equity Assessment Review, or HEARS, and will be presented by Kai Wong. Kai is a managing consultant at the Lewin Group, which is part of OptumServe Consulting within Optum Inc. His roles at the Lewin Group include client and project management, product and business development, and consulting team management. Now we will hear from Kai.
Good afternoon. We're excited to have the opportunity to talk to you today about a health equity solution that was developed by the data reporting solution team at OptumServe Consulting. In recent years, there's been a lot of attention and focus on health equity because populations or residents in poor, minority, or underserved communities have had increasing challenges in experiencing or accessing healthcare services. This was never more apparent than during the COVID pandemic, where many of those communities couldn't receive testing when testing first became available, or challenges with vaccines when vaccines first became available. The DRS team partnered with our Medicaid plans at United Healthcare and helped them to address or identify sites where they could conduct COVID testing and COVID vaccines as these services became available during the pandemic. Clicking on this tab will bring us to a landing page for a Tableau storyboard workbook. In this particular workbook, we're focusing on Texas. Since Texas has a large number of counties, also has some counties with poorer neighborhoods, larger concentrations of minorities, and also has some rural areas that are typically underserved as a result of a lack of healthcare providers. So focusing on Texas, we're going to look at each of the domains to see if we can look at health inequities or identify health inequities within El Paso County. To begin the demo, we're going to use the tabs on the top of the storyboard to access each of these dimensions of health equity. The first dimension that we're going to look at is health risk and disease burden. When we click on this tab, this is going to take us to a view. We're going to be able to see prevalence rates for diabetes at a census tract level. Darker blue census tracts have a prevalence rate up to 31%. Lighter blue census tracts have a prevalence rate down to 2%. As we evaluate this view, we see there's some areas of El Paso where the prevalence rate for diabetes is significantly higher. To further explore health inequities in these census tracts, we're also going to look at their access to care. And looking at access to care here, we're going to look at residents that have no health insurance. If we look at those same census tracts now, we'll see, again, darker blue is a higher value for that metric. We're going to see that there are some census tracts in the same region where a significant percentage, up to 62% of the residents, have no access to health insurance. Finally, we're going to take a look at quality of care. And again, looking at a census tract view with similar shading, now we're looking at cholesterol screening. So lower screening rates mean members are not getting appropriate quality. Higher screening rates, they are getting access to that service. And we see again that in those same census tracts, there are some areas where members are not receiving screening, so don't have great access to care. To continue evaluating health inequities, we're going to look at the social determinants of health of residents in each community. So here, we're now looking at actually a zip code level instead of a census tract, and the area deprivation index shows us what is the level of poverty in that community. The area deprivation index is developed using education rates, unemployment rates, income and housing to evaluate poorer communities represented by dark brown and more affluent communities represented by a lighter blue. And here in this example, we've chosen to look at how vaccinations distributed actually correlate with ADIs. We also have the ability in this particular view as well to dig into some of the characteristics of that population, whether it's age, minority status, or housing that community experiences. Finally, the last dimension that we've included in this demo is community resources. As we look at these different views and we identify communities where we believe there are some health inequities, who are the partners that we can use in those communities to help to address those inequities? Here, again, the shading is the area deprivation index now back at a census tract level, and we can drill into specific neighborhoods and see in some of these poorer neighborhoods where we're having challenges with health inequities, who are the actual healthcare facilities that we can use to go in and improve access to care for these residents. Finally, this tool has been created using publicly available data sets such as the American Community Survey and Places so that we can see where there's evidence of health inequities in different communities, and can actually be drilled into with more metrics and take a deeper dive with claims data, which we do in our companion tool, which we call HEALS, which is our Health Equity Alignment Solution.
Hello, Kai. That was a great presentation. Thank you. I really like those visualizations again.
I'm here.
Hi. So we have a question in the chat from Greg Dawson. How do you identify members of the population who have no health insurance?
That is actually, a popular data set, and I believe, it came from, from a CDC, it's on survey, I believe. It's the,
Okay.
it's a project called Place. Yeah. If you look at that, CDC, and then search, Place, that, data sets, and also some other that we reference came from there.
Okay, gotcha. What are the challenges in getting this data into the dashboard, into the tool, into the HERES tool?
Good questions. Just like our presenters, before me, is to look at it, so because we're on the publicly available data sets, so oftentimes the matrix is set up at different geographic units. So you can look at that at a county level. Some of those measures relating to this track, or even a those block groups, and numbers, people don't understand, what that means, so oftentimes, we also look at code level. So having said that, you have different, matrix, or measures, with different, units. So one of the challenges, is how to best use of them, in a single mapped view, how to layer each other, and can still, tell the story. And of course, the publicly available, and the source, they don't update, every single week, or every single, month. Some of those, census data or ACS, data. You have to wait, when available. There are some data require a little more, as such, to ingest, those data, and bring up, the most up-to-date, data information, onto the view. But that requires a lot more, and technology, solution behind.
Great. Another question from Sarah Halvik. Who are the primary users of the HERES dashboard, and do you know how they are using the information?
The first part questions, I guess the first part is potential user. When we put this, together, and again, any kind of organizations, or entity that belong to the health, can use or adapt, using this, too. So it go all the way from, the federal government, when they have, big populations, like, because in Medicare, they also, look at, health equity, as an important focus. Or the past, few years have this, COVID, the federal governments, also, have some of those, that address, emergency response surveillance. So I also think about, at any kind of the state and county level, they can also use this, for the use case. When we put together, a lot of, those, again, managing, the health efforts, of the members, for example, the managed care organizations or account care organizations, I can also see, they can also benefit, from the tool. When we look at the tools, it can be custom to, again, in here, like a population health, tool. Again, specifically, the tool can be also developed, for a specific, population groups. For example, again, we've been talking a lot about, health equity, and I see, to maternity, and, so that could be one specific, stakeholder groups, healthcare care systems, just to look at populations. Questions, is, again, overall, is, the purpose, the use case behind, is, when we look at the health equity, looking at different measures, it means so many things, and there's so many measures, all together. At the end, can we be able to identify, a area that has some common geographic surface area, so that we can do something about it. So one of the use case in here is to identify those pockets those area and we pick again Texas they have a lot it's a big area with a lot of counties. So at the end of the day you can identify, hey, show me the top 5 zip codes or the top 10 zip codes. I can do something about it. Health equity.
Great. Thank you. And I think we have time for one more question here. Did you run into any challenges pulling from multiple data sources to create a single dashboard that combines information from all of them? Did you find that they were generally compatible with one another?
Yes, as I kind of mentioned, because publicly available data, you have to learn to account, okay, this data set, is as of, the last 4 years, or 3 years, so I think, all of them, has limitations, it's not necessarily up to date, but at the same time, again, once you clearly identify, the years and the source of the data, everything what we see in here is, to provide different clues, like business intelligence, at the end, how all these pieces in together, collectively, and then identify, oh, is this zip codes, or this, area we need to pay more attention, health equity. And it's go back, to the domains, how you set up those domains, so, again, in here, we look at, populations in general, who are the people that, that they are sick, the disease, or health, the disease, burdens. And then you look at, hey, do they, take care? What services, do they receive? Also evaluates, do they get good care? And also what are the consequences, what are the negative, experience, adverse, outcomes, as such. So all those, point to, can't tell the story. And again, at the end, okay, those, so-called hotspots. Again, just to provide, some idea, where to start.
Gotcha. All right. Well, thank you, Kai, and thank you to the audience for the questions. Keep them coming. There will be another opportunity at the end where we'll bring all of the presenters back. The final presentation is titled Visualizing Determinants of Health, an Interactive Exploration of Healthcare Access, Quality and Cost Performance in Colorado's Neighborhoods, and will be presented by Ioana Crisan from Human Services Research Institute, or HSRI, and Maria de Jesus Diaz-Perez from the Center for Improving Value in Healthcare, CIVHC. Maria is the Director of Research and Performance at CIVHC. In this role, she works with external partners on research collaborations and with internal teams to advance healthcare performance measurement. Ioana is the Director of Healthcare Reporting on the Population Health Team at HSRI. In this role, she leads analytic and reporting deliverables for their clients in Colorado, Maine, and Oregon. So we'll turn it over to Ioana and Maria.
Good afternoon, everyone. Thank you for joining us. I am happy to be presenting today with Ioana Crisan from Human Services Research Institute. CIVHC's public reporting team and HSRI have been working closely in the analysis that we will be describing today. Today, we will be talking about the motivation behind this analysis. Ioana will talk in detail about the implementation of the measures that we used in this analysis, and we will close talking about limitations and next steps.
Hi, everyone. I'm part of the HSRI, Human Services Research Institute Population Health Team. Our organization is a mission-driven nonprofit organization that has been in existence for over 45 years. We have partnered with CIVHC for the past 5 years and helped transform the Colorado APCD into a high-quality data source.
As many of you know, CIVHC is the administrator of the Colorado All Payers Claims Database since 2012. And our mission is to provide, work with a variety of partners from individuals to communities to providing healthcare performance information to improve Coloradans' health, healthcare quality, and reduce healthcare costs. One way we do this is by producing public reports that those working to change healthcare can use to monitor their progress. In late 2020, CIVHC published an enhanced community dashboard that describes how cost, utilization, and quality vary through among payer types, through the years, and among counties in the state. The dashboard overall shows great progress in the state of Colorado, but also shows, as you can tell by this map, great variation and therefore uneven progress. There are many factors associated with healthcare disparities in healthcare among counties, but evidence show that racism and socioeconomic factors are important factors describing disparities in different populations. For example, living in socioeconomically disadvantaged neighborhoods has been associated with higher mortality and readmission risk. For this reason, it's very important to measure healthcare performance and its relationship with socioeconomic factors, and has become a priority for many state agencies and healthcare organizations. One of the challenges to do that is that, as you know, we have very limited information at the individual level on characteristics like education, income, on housing, and changing that will be time-consuming and resource-intensive. One commonly used alternative to display socioeconomic measures has been to use area-based information. Area-based information is feasible because we can use patient home addresses that are routinely collected and updated in administration. And these addresses can be geocoded and linked to external data sources like census data that is publicly available. It is important to remark that this is an alternative to individual level data, but never a substitution. And ideally, we will have both. This analysis will be a dashboard that illustrates the association between selected healthcare measures and selected social characteristics at the neighborhood level. The target audience is state and local offices and healthcare systems, and the unit of aggregations we chose is census tracts that we call neighborhoods. We chose census tracts because they demarcate homogeneous populations, and they are used for resource allocation by federal, state, and local governments. We chose a selected set of healthcare measures used in the community dashboard, and they were selected by their relevance to the state. And we also chose a selected set of social characteristics based on literature and availability.
So to develop this dashboard, first and foremost, it was necessary to assign census tract identifiers to co-APCD person addresses. In other words, to enhance the co-APCD data with the geolocation information. We acquired a set of social determinants of health statistics that Maria described at the census tract level from publicly available data sources, and constructed the healthcare measures again at the same level based on the enhanced co-APCD data. And of course, as the last step, we developed the interactive dashboard itself using Tableau. We did this we enhanced the co-APCD through geocoding of all person addresses. This was a resource-intensive process. We assigned 15 million address observations to one of the 1,200 census tracts in Colorado. And then we integrated it back into the APCD data warehouse, which allowed us to tie census tract identifiers to eligibility and claim records. For healthcare measures, we have selected 2019 as the measurement year for most measures. As per CMS rules, the publishing of data derived from counts less than 11 is prohibited. So as you can envision, the grouping of measures by census tract did result in a higher share of geographies having their data suppressed than for the counties or county-based regions that are displayed in the community dashboard. So our strategy to minimize suppression was to combine multiple years. We applied this strategy to one of the healthcare measures. For SDOH statistics, we are using measures sourced from the Census Bureau data, specifically American Community Survey statistics, which are estimates based on 5 years combined data. We are also using two subcomponent themes from the Social Vulnerability Index in 2018 iteration, which is also based on the 5-year combined ACS statistics. And we are using statistics on the racial and ethnic composition of the neighborhood to provide this information for report viewers, once again from ACS. The next slide shows you a quick summary of the count and percent of census tracts that are missing data for measures displayed in the report. The highest percent is still for the healthcare measure, for which we combine 2 years of data.
And this is a screenshot of the interactive dashboard that we will be publishing soon. In the top left corner, the user can select the healthcare measure of interest and the social determinant of interest, and that relationship will be plotted in the top right graphic. And in the bottom, they can see a map, and they can observe how this relationship plays into different geographic areas in the state. The pie charts illustrate the race and ethnicity breakdown in the state and compared to specific selected regions. This is just a zoom in of the plot for the visualization of the relationship between emergency department utilization and level of poverty in neighborhoods in Colorado. As you can see here, neighborhoods with lower level of poverty have also lower levels of emergency department utilization. And the colors in the graph indicate the census tracts or neighborhoods that are rural and the neighborhoods that are urban.
There are a few limitations to be aware of for this analysis. The healthcare measures in this dashboard do not represent the full universe of healthcare services in Colorado. They are based on claims data submitted by health insurance companies to the Colorado APCD for over 65% of insured Coloradans, but excluding self-pay and uninsured, excluding the majority of people covered by self-insured employer plans, and some other exceptions. Then, for some co-APCD addresses, we may have just the city and state and zip code information, so we're missing the street details. In this case, the assigned census tract is based on the geographical center of the city or the zip code tabulation area, which may or may not be the same census tract if we had access to the full street detail. A similar scenario applies also to the subset of addresses that represent PO box addresses. Generally, we worked with APCD addresses that have been minimally cleaned or validated after confirming that the geocoding tool is able to produce meaningful results, even for misspelled addresses or addresses with small errors. A substantial portion of co-APCD addresses were matched to high-quality geocoding output. This is information based on the accuracy flags provided by the geocoding tool. However, a small subset have lower accuracy, and the subset is closely related to the scenarios I just mentioned. For the social determinants of health statistics, ACS data are a great data resource available nationally. However, they do represent estimates, are published with margins of errors, and the magnitude of the margin of error can vary a great deal depending on geography and measure. But despite all of these limitations, this dashboard is meant to provide directionally accurate information on the relationship between healthcare measures and social determinants of health.
We will be publishing the dashboard in early 2023 and publishing a white paper detailing the implementation of geocoding. More importantly, we'll be adopting and developing composite measures that are relevant to the state of Colorado and to the community-based organizations after a listening tour that we will be conducting with them. Thank you for joining us today, and we are open to questions.
All right. Thank you, Ioana and Maria. Great presentation. More beautiful visualizations. I love it. It's really nice. Nice job. So let's see some questions here. Do you have access to any individual level social characteristics that can be added to the dashboard? And if so, are you planning to use them in the future?
As you know, all payers claims data is not characterized for huge richness of the sociodemographic information, but we have sex, and we will be starting to collect non-binary categories also. We have age, and we also have improved considerably the race and ethnicity data in the APCD. So soon we will be able to be implementing that at the individual level, which would be great. And there are many other pieces of information that can also be used from claims data. One that we will be collecting, that we started collecting just now, is language preference, but there are also other important characteristics that is like use of services for, like, if you have mental health conditions in the like high prevalence of mental health condition throughout life for individuals, that can be also used as and it is an individual level. We can also use information from the mothers, moms who had problems with substance use or something like that, and that would be also important information that provide context to healthcare outcomes, healthcare performance also.
Great, thank you. What could Colorado's communities learn from looking at this dashboard?
Well, I can take that also. One thing that we would love everyone to learn, and not just communities, but when we say communities, that can be mean many things. The population that is represented in the all payers claims database is only covered populations. If you look at it, is considered that one of the most important barriers to healthcare access is just having insurance. Well, everybody here has insurance. Everybody here that is represented in these neighborhoods has already 11 months of continuous eligibility in their respective payer types, and they are still not accessing care. And there are many factors in the communities, in the neighborhoods, that might be related to those to them not accessing care in that case, or to them accessing the ED instead of regular care in other examples. So what I would love to see, and I know that this is not going to happen just by looking at the dashboard, is to start this raising awareness and discussion about, and I think Elizabeth mentioned that, what are the hypotheses behind this relationship? Of course, we just showed a screenshot, but if you look at the interactive dashboard, you can see what are those neighborhoods that have high poverty but have actually better healthcare performance compared to other neighborhoods with high poverty. What is happening there in those localities that is actually preventing people from going to the ED as much as in other equally poor neighborhoods? What is preventing? What are the factors that are in place? Is there any more care coordination programs or access to more social services? What's going on? And I think it's at the local communities where the hypothesis, the better hypothesis and the better actions can take place. But we know that it's not going to happen just by publishing. We need to do to work with communities and work with people who can actually make a change down in the ground. Ioana, you want to say something?
That was great, Maria.
All right, thank you. And I think we can take one more, and then we'll bring everyone back for the whole panel. From Greg Dawson, what % of data has usable race ethnicity values in your data set?
Like right now, actually, it improved considerably, and depending, we haven't, we started with 80% of data not usable for commercial covered individuals. And right now we are more like a 15% overall for the whole database. And that depends on what population you are representing at a time, because we have done different analyses with different purposes. So we have younger population or Medicaid population. Medicaid is much better. For example, we have almost like 98% of the race ethnicity data is usable. And it is the best, actually, in the state at least. Medicare is second, and commercial payers are the most uneven, but improving significantly. We are like in the 10% right now with unknown ethnicity or race.
Great, thanks, Maria. All right, Charles, how about if we bring back the whole panel? Here's Kai. All right. Hi, everyone. Nice job. Thank you very much for putting together these presentations. They were all great. Looking at the chat, just making sure that we addressed everyone's questions. I think there were a couple we didn't get to. So for Elizabeth and Caroline, there was a question about did you hear any concerns from stakeholders about collecting claims related to abortion care services in your project?
So unfortunately, we did not. So what we really did hear from stakeholders' concern was really the granularity of data and the accessibility. They really wanted to know what was going on in their backyard. Unfortunately, that is the limitation of using some of these data sets is we can't get as granular as people would like. Even if we did get at a zip code level, they really wanted to know at a neighborhood level. And so that was a lot of what we heard. And another on topic areas, they did want to know a little bit more about just basic needs. Were people accessing or do they have access to food? Obviously, healthcare facilities and things of that nature.
All right, thanks, Elizabeth. And then there was a question from Evelyn Lee for you, Kai. Is the HERES tool available to the public?
We work, again, when we put together the HERES tool, is specific, for a clients, and also for the objectives, so at the moment, you don't see, HERES, in a public domain, so, but any individuals, is interested, in hearing more about and building a HERES, specific, for the use case, just, let us know.
All right, thanks, Kai. And a reminder to the audience, if you want to put questions in the chat, we'll address them. I had a question for the Civic and HSRI team. Can you speak more to the geocoding process if you're able to, as far as are you using publicly available data? Are you using a third-party tool? Can you speak a little bit more about that?
Sure. We are using a third-party tool, which is a HIPAA compliant tool. We're gonna present a lot of information about the technical specifications and the process in the white paper that Maria described. And this was by far the most intensive part of the process of developing the dashboard that we just presented on. This is a process that is performed annually for the person addresses in the Colorado APCD data.
Great, thank you. And here's a big question for anybody and everybody. So you all have been working on these with these great data assets and have put together some really powerful visualization tools. Are you aware of? Can you speak to any impacts that that maybe you've seen or heard about as a result of people using these data and these tools? It's a big question.
Jeff, I can go, and share a little bit, of our experience. We actually have something very similar, and again, feeding all the information, instead of what we call the HERES, is another tool called HEALS, but it's the same construct, which, we look at measures, relevance, to each domain, which is important. We even enhance, to come up with, what we call health equity, kind of an index, which identifies, which, zip codes, has the most, impactful, relating to health equity. So we work with, managed care organizations, with about 50,000, plus, plus, using that tool, the management, they identify pretty much, hey, if I wanted to improve, have a member campaigns to improve, breast cancer screening, as well as, colorectal, screenings, what would be the area, most impactful and where I should start, the campaigns. So they pretty much, use, the tools, from HEALS, similar, to identify, those zip codes, area, for initial, outreach, and, education, as such, to the member as well as, to the physicians.
That's great. Any other thoughts from the team?
I think it's gaining a lot of interest. I know we've been working with funders in Texas to kind of look at to evaluate programs using both our claims data and this SDOH data together. And so there's lots of interest from groups to kind of seeing what like social services, are they really impacting health outcomes? And so we're seeing more and more in that. And so we're working on a couple of projects around that scope.
That's great.
I can add, our dashboard is not published yet, but we have published other, like the community dashboard I was talking about, that shows great variation, and we have done several presentations and just call attention to the potential things that might be related to that variation. And since we have worked particularly with community-based organizations working in the state, they are very familiar with the counties and what is available in the county. So you can tell how the variation is usually related to lack of access, like physical access, and also poverty and other socioeconomic conditions. But I would like to bring back what I think all of us made stated over the presentation, first Carolyn and Elizabeth, and also Kai, about the importance of making this information more like friendly to the user, and making sure that people know what they can do with it. And probably they cannot do anything with it, but what they can do is generate those hypotheses and just build the base to go deeper into what they can do within their localities to make a change. And I think that's what we are here for. And then we can monitor their improvements later.
That's great. Thank you. I think we have a couple more minutes. For the dashboards that are being made publicly available, what kind of a vetting process do those have to go through before you release them?
And are you going, Elizabeth? I can tell you about Colorado. The APCD has an advisory committee, and the advisory committee is central, not only in when we release the dashboard, but also before, when we plan the dashboard. What are the measures that are more relevant to display? And since the idea, let's say, they have a role, and then they are also weighing on like how it is displayed, and how to label, and also how to best disseminate it. Is that perfect? No. And that's why we are going, that's the beginning only, and then we'll go and work with other community-based organizations that are not represented in the advisory board, because we have a large representation of all the sectors in healthcare, but it's not everybody. So we would like to get to more people.
Great.
For sure.
Thank you, Maria. Well, thank you all again for your time with these presentations and taking the questions. And I will turn it over back to you, Charles. Thanks again, everyone.